welcome. My name is Mariangela Pellegrini. I work for the ERA Neuroblonet as patient education and patient program manager. And it's my great pleasure and honor to welcome all of you on this Global Action Network for Sickle Cell Disease and Other Inherited Blood Disorder Congress. Thank you very much for letting me chair this session. It's really a pleasure. So before starting, as you may know, this session will last 60 minutes. With me, there will be two key speakers that we are going to present. But before that, I would like to share some home rules. So first of all, as you can see, this session is recorded because the video will be available and implemented in GAMSIT website. So www.inheritedblooddisorder.org. So we will have two presentations of about 15-20 minutes each. Then we will have the Q&A session. You can write your question in the Q&A tool or in the chat. I will moderate it, so I will not miss any of your comment feedback. Also, please be kindly informed that at the end of the session, 5 minutes before, you will see a survey popping up. So it's very important for us if you could answer the survey. And so what else? Yes, so last home rules. Please kindly note that you have at the bottom in the bar that you can see in the Zoom screen, you have a check box that you can click for enable translation and listen to this webinar in your language. If you need technical help, please do not hesitate to write. And now I can finally come to today's this time lecture. So making the promise of innovation, a reality for all, global access to gene therapy and other new therapeutic approach. As said, we meet two key speakers, expert in this field, Dr. Cantor Julie and Dr. Raffaella Colombati, that I will please kindly ask them to unmute and introduce themselves. Then we will have first Dr. Cantor with the presentation, and then Dr. Colombati. Thank you very much.
Thank you very much, Dr. Pellegrini, and thank you to the GANSID for inviting me to speak here today. I am Dr. Julie Cantor. I am the director of our adult sickle cell disease program at the University of Alabama, Birmingham in the United States. I'm also a professor of medicine and pediatrics.
I am Raffaella Colombati. I'm a pediatric hematologist, and I'm the director of the Veneto Region Sickle Cell Disease Pediatric Reference Center. And I am associate professor of pediatrics at the University of Padua in Northeast Italy, so Europe. I've been asked to speak about global access to innovative therapeutic approaches for hereditary blood disorders, which I found really challenging and a very broad topic. And so, moreover, I was asked to speak about policy and, just a second, I can't move, okay, and educational perspectives. So when we talk about global access, behind this wording, there are several meanings. It means that every patient in any part of the world can obtain it, but also that every physician in every part of the world knows or should know how to prescribe it, to monitor its effects, and to manage it. And when we talk about innovative therapeutic approaches, just a second, okay, it might mean that we are talking about new drugs, but new therapeutic approaches with old drugs or old treatments, new curative therapies, or new combination of therapies that were never thought before, like multimodal therapy. So it's really complex, and it makes us have to consider different steps. And then hereditary blood disorders, which can be red blood cells, coagulation, or white blood cells, But what I'm going to focus is today's red blood cells and specifically sickle. So global access to innovative therapeutic approaches in sickle cell disease. Now, recently, the Lancet Hematology published a Lancet Commission on sickle cell disease the past summer, and several topics were addressed to improve outcomes in sickle cell disease. And you can see that one of the problems that was identified was to establish, to improve access for established and emerging treatment, which is the green one in the center of the page. And the other one was how to improve access to cellular therapies. So these are for sure some topics that both the medical and healthcare community and the patient community feel are important. And when we talk about this, we are talking about established treatments like blood transfusion and hydroxyurea, but also we're talking about emerging treatments. And if we consider the 12 recommendations that the Lancet Commission made in the document, we can see that number 3 deals with making hydroxyurea accessible and affordable to all people by 2030. And then the other one, number 4, is improve blood transfusion supply and safety by 2030. And then we also have number 5, that balance participation of low middle income country and high middle income country in clinical trials for new therapy. And number 6, accelerate the development of effective and affordable therapies to achieve safe and accessible cures by 2040. But then we have another issue. We need to educate healthcare professionals and the general public about sickle cell disease and its management. So these include many problems regarding old and new drugs and their access and education, both of the scientific community and the patient community. And when we think about a global access, we have to think that birth prevalence and prevalence are not the same. And they're different. And this is, again, a recent picture from the Lancet Commission that shows how the number of births is different. So it might mean that the number of people to whom you have to offer and make access this treatment is different, might have different costs on the people or the countries. We also know that the prevalence of sickle cell disease, not only the birth prevalence is different, and in spite of the lack of data, again, numbers have an impact on access and cost. From a global perspective, even mortality might not be the same. And we can see in this slide that in spite of having not enough data to evaluate comprehensively the mortality and the reason of mortality in the various geographic areas of the world, we still have different figures. So survival might be different, and we need to have drugs, for example, for different ages that are different in different countries. And again, from a global perspective, disease burden might not be the same. And we don't have time to go through all the chronic organ damage data that are available, but I'm just showing a simple concept regarding acute complications like painful crisis. And this is an example from the Kazir court in which the admissions and the emergency room access in various parts of the world for the different genotypes were different, with higher admissions in UK and Italy, so in Europe, and lower admissions, for example, in Ghana. Is this because people in Ghana have less pain, or is it because the healthcare organization is different? And again, pediatric and adult might be different. So again, if we look at the access to treatment from a global perspective, there are many considerations that we need to make in different aspects of disease burden, disease mortality, disease prevalence, disease characteristics, but also organization of the healthcare systems. Otherwise, we will not take into consideration all the variables that are needed to guarantee access in every part of the world. So how can we achieve global access, and which steps do we need to take? The first one is that we need to demonstrate that a new drug or an innovative treatment works. And this means efficacy of the drug, safety, and dose that is demonstrated in trials. But this needs to be done in different settings and in different age groups, for example, adults, teenagers, and children. When we have demonstrated this in clinical trials, we need to get the new drug approved in each different setting and for each age group. And after that, we need to get the drug marketed in each different setting. And only in that case, we can have a global access. And then we might also need post-marketing or real-world studies for confirmation. But we have to keep in mind that regulatory agencies in different areas of the world are different and might not request the same data to give approval and license marketing of a drug. And these are just some of the examples of different regulatory agencies. And we know that drugs have been approved differently in different settings for sickle cell disease. National authorities that also grant marketing might work differently. And in order to think with a global perspective, we need to team up. For example, EMA, which is the European Medical Agency, which is undergoing a revision in this time, and this process will take, let's see, quite some time. One of the discussion points is how do we collaborate with other regulatory agencies in order to team up and reduce the burden or reduce unnecessary steps in the approval and marketing of drugs. Moving on, and going back to the question that the Commission had about making access to established and emerging treatment, one thing is that we have to consider that innovative therapies are not only new drugs, but is the process of rethinking and optimizing all drugs and all therapeutic approaches. For example, for sickle cell disease, we have has established a standard of care: hydroxyurea, red cell transfusion, bone marrow transplantation, and pain management. But do we have innovative treatments and therapies for each one of these? Yes. For example, for hydroxyurea, we're talking about dose optimization and personalized dosing. For red blood cell transfusion, we have to reduce risk of alloimmunization. It's not only granting access to safe blood, but also optimizing the blood that we have to reduce the risk. For bone marrow transplantation, we have to increase donor pool and safety and reduce long-term effects. And regarding pain management, we have to personalize and optimize schedules and reduce opioid dependence. So you see, innovative therapies are not only new drugs and new procedures, but also the optimization of old approaches. And this is just an example, for a precision medicine to optimize HU in pediatrics using a pharmacokinetics approach. The other one, for example, for hydroxyurea, is broadening the indication for specific issues, for example, stroke prevention in low middle income countries. Or again, when you have an approval and an indication, then you have national authorities. And I put you this example regarding Italy, in which you can see the green lights is where hydroxyurea at a pediatric dose can be accessed by the patients. In yellow one, those where it is complex, and the red ones, those areas of the country where children do not have access in spite of the approval by AMA, the approval by the National Italian Pharmaceutical Authority, AIFA, but then there's a problem of reimbursement. And each reason we have a federated government walks by themselves. So you have children living in the green area that have the drug for free, children living in the red areas that cannot have access to the drug. And then moving on to two examples that I want to make. And one was crizanlizumab, which had great results for a phase 2 trial in adults. So the FDA approved the drug in the USA, but EMA did not follow the same reasoning, and so gave a conditional approval, but requested a phase 3 trial that gave different results from the phase 2. So there was a huge enthusiasm and optimism by patients and physicians in the beginning, but then EMA withdrew the approval. And now many patients do not benefit from the drug anymore, and physicians do not have alternatives. So there's a lot of disappointment and, of course, less access. So again, you can see in an example of which steps of the flow from the invention of a drug and the testing of a trial, that's not enough to have access to the drug. And then another examples from the real world now, voxelotor was approved after successful trials. It's marketed in the US and has abundance of real world data from the US. But in spite of a EMA approval in the EU, it's slow to be marketed, and there are inequalities in access among countries in the same geographic region, for example, in Europe. And again, this is a disappointing for many patients that are waiting for treatment, or many physicians who are waiting for alternatives to prescribe to their patients. So my conclusion from this really broad group of thoughts regarding the global access to innovative treatments is the fact that the process of achieving global access is complex and requires knowledge of all the steps by individuals with a specific disease and by the caring physicians. Both need to be knowledgeable and be careful in each step. Then innovative treatments can include new drugs, but also the repurposing of drugs, new schemes, or new innovative multimodal therapies. We must learn from the mistakes of the past. The enthusiasm of a clinical trial is not enough to grant day-by-day access to an effective compound. And if we want to think globally, we have to team up experts, regulatory agencies, companies, patients, because that will help reduce costs. And with costs, I mean also time, wasted time, intervention, but with specific consideration for local needs. And I thank you for your attention.
Thank you very much, Dr. Colombati, for this comprehensive speech. So now we go to the second one, so Dr. Cantor. And I also encourage the audience to write their question, because this is an unique occasion for asking directly to expert any curiosity or question you may have. Please, Dr. Cantor, the floor is yours.
Thank you very much. And actually, I think this worked out the way it should have, because it was perfect for Dr. Colombati to present first. If she thought her topic was hard and broad, I would say that this one is even more broad and harder. So I sort of rewrote this as, where do we even start when we're thinking about global access to gene therapy? These are my disclosures. I do consult for gene therapy companies. However, there is nothing related to those consultations in my discussion. So we're going to just very briefly review the pathogenesis for sickle cell disease, because it really tells us why we're talking about gene therapy. We'll talk about what we know of allogeneic transplants. That's transplants from a donor. And then we'll talk about the genetic therapy approaches in sickle cell and how we increase access to those therapies. As a reminder, there's just one small gene that causes all of these downstream problems. The abnormal hemoglobin that is resulting from that gene is the hemoglobin S that we are all familiar with, that sickles and causes abnormal polymerization, that not only causes problems with pain, but also with organ function and decreased lifespan. And truly, sickle cell disease is a multi-organ disease. I like to remind everyone of this, because sometimes it seems we can fix the blood without fixing all of the other problems that occur. And that has to do with the abnormalities of the red blood cell that cause damage to the blood vessels, because it's stickier. And it's that blood vessel damage that causes all of these chronic organ problems. So this is a blood disease that becomes a vascular disease. And why does that happen? Well, we know this multicellular adhesion blocks blood flow and causes pain. But what we also don't always talk about as much is that every time the blood flow is blocked or there's vasoocclusion, the blood vessel is also injured. And if you imagine this as a car, if the blood is a car, every red blood cell is a car, and the road is the blood vessel. Think about how when cars have accidents on the road that they damage the road. Well, every time these blood vessels get stuck, it damages the side of the blood vessel. And that causes a lot of downstream problems, some of which cannot be fixed, even with curative therapies. So allogeneic stem cell transplant, allo means transplant from somebody else, is a known curative therapy for sickle cell disease. And we know that hemoglobinopathies are ideal for this type of approach because the hemoglobin stem cells, our blood stem cells, are actually vehicles for therapeutic gene delivery. What does that mean? Well, in some ways, an allo transplant where we get stem cells from someone else are delivering a healthy hemoglobin gene. It's almost a type of gene therapy. And we know that if you're perfectly well matched, that can be very effective. We also know that someone can donate stem cells if they have normal hemoglobin, which is hemoglobin AA, that means they have 2 adult normal hemoglobin genes, or if they have sickle cell trait and they have hemoglobin AS, because we know that people with sickle cell trait lead relatively healthy lives and do not have complications of sickle cell disease. So we know that by using this transplant and having someone make healthy give you healthy stem cells that then produce healthy hemoglobin can really halt the complications of sickle cell disease, resolving many of them. We don't know, however, if you have significant organ damage before you get your transplant, how much of that can be reversed. And that is still data that needs to be collected. So there are 3 main types of donors from someone else or allogeneic stem cell transplant. The most common and the safest is a matched related transplant. That is from a brother or sister with the same bone marrow type. And the majority of people in the United States do not have a matched sibling, which has really limited the number of people who are able to get this highly effective curative therapy. Again, important to recognize that this is recommended if available. There's a matched unrelated, where the 2 types of bone marrow match, yours and the donor, but you're not related to that person. And this has really had overall suboptimal outcomes and is rarely used at this time. And finally, there's a half-matched or haplo-identical, usually from a mother or father. These are important because everyone at some point had a mother or father, although not always healthy or available to donate cells. This increases the number of available donors for people with sickle cell disease and has significant potential for widespread availability and access. But even in the United States, there's a lot of people with sickle cell disease who never are transplanted. Well, why is that? Well, many adults don't even have access to a sickle cell disease specialist or a hematologist. Not all hematologists are sickle cell specialists. So if patients can't even get routine preventative treatment and care or get access to the therapies that Dr. Kalambati talked about, how will they get a stem cell transplant? How would they get access to a transplant center? And very importantly, when you get an allogeneic transplant from somebody else, you require huge amounts of long-term follow-up where your blood is checked for the immune suppression. Immune suppression is the medicine given to help prevent graft rejection. And that means needing to be very close to a transplant monitoring center or physician who can do this immune transplant monitoring. So when we think about gene therapy, there's some really exciting potential benefits in that there is no risk of graft versus host disease and very little risk of graft failure. So people don't need that long-term immune suppression monitoring. So let's think about gene therapies then for hemoglobinopathies. This is the process being used at this point for all of the current gene therapies. We're harvesting stem cells from someone with sickle cell disease using peripheral apheresis. That means we don't need to do the bone marrow to get the stem cells. We get them out of a vein, usually through an apheresis process. And that requires having a significant amount of technology to do that apheresis and collect the right cells. Those cells are then sent to a lab where they're genetically modified. And then when those cells are ready, we bring the affected patient back and they get myeloablative chemotherapy meaning very intensive chemotherapy, and then they get their own cells back. Now, this is incredibly exciting because patients are now serving as their own donors. They don't need someone else to donate. So this could be available for many, if not most, individuals with sickle cell disease. There's no need for immune suppression and no risk of graft versus host disease. The most common, or the one you've heard the most about, is gene addition therapy. This is the paper that we published, or two papers we published on this therapy, now known as lentiglobin or lovo-cel. In this therapy, we are giving individuals with sickle cell disease, we're actually giving their stem cells a gene that produces healthy hemoglobin A. It's marked so that we can identify it differently from transfused healthy hemoglobin A. Here are those results from the study. And I want to point out a couple of important things, but first I want to orient you to the slide. The green here represents hemoglobin S, or sickle blood. The pink represents what we're targeting, or hemoglobin A with that special T87Q marker. On the left, this is the first group of patients that got this therapy, called Group A now. And you can see a whole lot more green than pink, and that is not what we wanted. This means that people didn't have the full response. They only are making a little bit of that pink hemoglobin. That's for a lot of reasons. They didn't get enough copies of the new gene. The cells they got weren't strong enough. There were a number of issues that we recognized after these first few patients. But importantly, you can see that even with very little pink, that pink goes on and on and on, and we're all the way out to 60 months here, 5 years. So we know it's very, very durable. Now, when we made changes to that and really significantly improved it, you can see on the right how there's a lot of green, but a lot of pink, almost 50-50. This almost looks like somebody with sickle cell trait who has 50% hemoglobin A and about 50% hemoglobin S. We're not quite there yet. People with sickle cell trait always make more A than S, whereas here, most people are still making more hemoglobin S than hemoglobin A. Again, you can see it's highly durable. We're 3 years out. People are making plenty of hemoglobin A, and it is a very excellent response. One of the ways we measured this response was looking at vaso-occlusive events. I really prefer to think of these as acute pain events because we don't know if they're truly vaso-occlusion or just pain. On the left, you can see the blue dots. Well, the blue line, each of those blue lines represent an individual patient. The blue dots are the number of times they had hospital admissions for pain events prior to getting this therapy. On the right side, you don't see any blue dots. Again, recognizing that none of these individuals had severe vaso-occlusive events, or as I prefer to think of it, acute pain events, didn't mean they did not have pain. It meant they didn't have to be hospitalized for those painful events. We also wanted to measure whether this worked by looking at hemolysis. We know that hemolysis is an indicator of sickle cell disease. Those cells are unstable because of the sickling, because they break down easily. And one of the best ways to see if this therapy is working is to know whether or not those markers of breakdown or hemolysis are actually still there. You can see in the first panel, lactate dehydrogenase, which is a sort of a poor person's marker of LDH because we don't have, of hemolysis, we don't have a great marker, but this is our best representative marker and tells us a lot when you compare it to someone's baseline. And it significantly decreases and improves, and in fact, almost normalizes. This really tells us that with the amount of hemoglobin A people are now making, their cells are not breaking down. I'm going to switch now to the bottom panel. This is bilirubin. Again, they were very high in the beginning and very low into normal range after this therapy. That tells us there's almost no current hemolysis. The middle panel is interesting. This is reticulocytes, or new red blood cells. While it is significantly improved from baseline, it is not quite normal. And this is something that we're ongoing studying because we're trying to figure out why it is not quite normal and if people with sickle cell disease have some more ineffective erythropoiesis than originally thought. When we think about gene editing, this is the other main type of gene therapy being done. The stem cell collection is done the same way, but here they electrically shock the cells and place in this combined guide. It's a DNA or an RNA guide plus Cas9, which is like chemical scissors. This bundle tells the chemical scissors where the abnormality is and where they need to cut the cell. And then it allows that Cas9 or chemical scissors to cut the cell. Current therapies then allow this to fill in randomly. So it disrupts this cell. It doesn't replace it, it disrupts it. It's highly precise. So right now we are really targeting gene that causes the fetal hemoglobin to turn off, and we want to turn it back on. That gene is the BC11A. It acts as an off switch for most people after birth. So this gene therapy goes in and edits that, cuts that gene, and makes it disrupted, which turns fetal hemoglobin back on and hopefully continues to prevent sickling and problems. This is called exa-cel. It was recently discussed in the EHA meeting in June of this year by Dr. Locatelli. And I'm showing you that schematic of where it is breaking the cell on the right side. It is again an autologous product. And what we can see after that is that people make a lot of fetal hemoglobin, which is what we're looking to happen. So they show this in their results on the left by percent fetal hemoglobin. So that is how much fetal hemoglobin they are now making. They went from very little to quite a lot. That fetal hemoglobin should also prevent sickling and pain. Importantly, however, they only have very, very few people who are more than 2 years out. So we don't know, like we do with lovo-cel, about the durability of this therapy yet. On the right side, they're asking, is that fetal hemoglobin present in every red blood cell? And it nearly is. So that's important to say whether or not that will prevent the cell from sickling. The mean fetal hemoglobin was 36.8 at month 3 and was maintained around 40%. There didn't show total hemoglobins here, but it's around 11. And importantly, it's not quite as high as the lovo-cel. Now, they have showed us again the importance of not seeing severe painful events after therapy, which is just like what I showed you previously. On the left side, it's telling you how many severe acute vaso-occlusive or painful events they had prior to therapy. And on the right side, it is showing you how many they've had after. They have one person who's had a few and one more person that's had one. And they do see that these individuals had a significant decrease of crises. We also, of course, know that post-therapy, most people do not require any transfusions. Importantly, we don't have that hemolysis data. So we don't know yet exactly the full impact of this therapy and how much it reduces blood cell breakdown of hemolysis. So now we need to think about the process. So I told you about the therapies and why we're doing them, but I want to really touch on how complicated this process is. This is a slide that has been presented previously, so I should have taken the confidential off of it because it's no longer confidential. It has been publicly presented and published. But what's really important here is recognizing all of the steps. We have to first collect those stem cells using apheresis. This is important because it's very complicated. Even places that do plasmapheresis for other conditions may not have ever done this type of stem cell collection. They have to be collected in a very short amount of time and then shipped off to a lab. And we have to make sure the cells get there while they're fresh, because the next set of processes is all done on fresh cells, where they initiate that manufacturing of the product, whether that's electrifying the cells to get that Cas9 CRISPR in or giving it the new gene using the vector. Once that is all ready to go, we bring that patient back in, give them chemotherapy, and they receive their product. And then they have to wait in the hospital while all those happy, healthy stem cells actually go back to where they're supposed to go. I like to show this because I think a lot of people think of gene therapy as easy or quick. And this isn't true. It actually is very complicated. And this whole process usually takes 4 to 6 months when it is all completed. So what is required then to do gene therapy? Well, we need safe access to red blood cell transfusions, both before we collect the stem cells, because it makes the bone marrow healthier to give us healthy stem cells, and after. We need to make sure the blood bank locally can do that transfusions in a very safe way with minor antigen matching so that the cells are the right cells for those patients. You have to have a cell therapy lab that knows how to collect those stem cells and then how to ship them very quickly to a lab that can do the gene modification. And then you have to have a transplant center that can do the busulfan or chemotherapy for the patients and support them while they're waiting for those new stem cells to swim back. They have to have infection management, blood pressure management, and seizure prophylaxis. And something I didn't include on here is pain management and pain treatment during this process, because these patients get very, very bad mouth pain from the chemotherapy, but also because they may have had pain from sickle cell problems before the therapy. Then they need to be able to have ongoing follow-up. So how will we do this in a more global setting? Well, there are sort of two options. One is a decentralized network of gene therapy centers, where we'd have gene therapy labs in multiple countries. Now, this is effective, but it's a little bit more costly because each gene therapy lab has to be maintained. We've already seen problems with this in Europe for the thalassemia therapies, where they did not have enough money to maintain those labs while they waited for the countries to decide whether or not they would actually allow the cost of this therapy. In these labs, people have to really maintain their training, their fidelity to make sure they can do what is needed. And you have to have sickle cell disease gene therapy centers in multiple countries who have to be able to maintain their transplant skills and practice. Another option is a centralized hub and spoke model of gene therapy, where there's a connected network of centers. Now you may have less centers, but more expertise at every center, where instead of bringing the center to the patient, we're bringing the patient to the center. While the same costs are required, it is less expensive if you do not need as many gene therapy labs. And you need to have those labs within a 6-hour flight of those stem cells so they make sure they can be appropriately manufactured. And this would hopefully provide spokes across many regions where, for example, where I am in Alabama, I could take a patient from several states over from Louisiana, treat them with gene therapy, make sure that they are stable, send them back home, work with a sickle cell specialist in Louisiana to make sure they get the right follow-up. So then which of these is easier? Do we bring gene therapy to everywhere, or do we bring everywhere to gene therapy? What I mean by that is, which of these is more going to create more access for our individuals living with sickle cell disease across the world? How do we use this centralized network of therapies? How do we make sure that we have enough international centers capable of the red cell apheresis needed and stem cell collection? And then how do we make sure patients are paid for to travel to these referral centers, to live in these areas while they await the stem cell manufacturing? How do we make sure they get back safely for transplant and follow-up? This is important to recognize again that while some of this seems more complicated, and it is more complicated and more expensive than allogeneic transplant, they are not at risk for graft versus host disease, and they don't require long-term immune suppression. So once the therapy is completed, it's actually easier than an allogeneic transplant. Before the transplant itself, it is more costly and more complicated. How do we first and foremost and always ensure access to care? How do we make sure everyone has a sickle cell specialist to even discuss this therapy with them? And we have to make this cost efficient by centralizing our expenses, ensuring a robust referral and receipt process so that we can bring patients to therapy in an effective way and then bring patients back home where they can be cared for. With that, I'm happy to take any questions.
Thank you very much, Dr. Cantor. So I see a first question in the chat. If we can take the document after the presentation. As said, so all the material will be on the Gansit website, so it will be updated there. And we have also comment, great presentation. And question. So I will go with the first question. So let's follow a little bit the order of the speech. So first for Dr. Colombati, which challenges do you think are the greatest to ensure global access in sickle cell disease?
So I think some of them I explained them during my presentation. So it's not just having a drug approved or having a drug that works as demonstrated in trials. There are many steps, but I think one of the first is the education of physicians and individuals with the disease, because if we are not enough knowledgeable of drugs, the safety, the efficacy, different ages, it's difficult to work to obtain the access. So access is not granted when a drug works, and we need to partner together in order to have access. I think this flow is a challenge.
Thank you. Dr. Cantor, do you want to add anything on the same question, even if it was addressed to Dr. Colombati? I mean, you are.
I think it was all said very well. I don't think I have anything to add.
Okay, thank you. So we go now with the question for you, indeed, Dr. Cantor. So which do you think is more complicated for people in low middle resource countries, allogeneic stem cell transplant or gene therapy?
So I have two answers to that question, I think. I think that the actual gene therapy is easier if it is done at a centralized center. So if you imagine that, especially in Europe, where it doesn't take long, right, to get from Italy to Germany, you could have centralized centers and you don't even have to have one center in every country. And that is really appealing because the follow-up requires a sickle cell specialist. It doesn't require a transplant doctor, and it doesn't require ongoing blood assessment for those immune suppression issues. And that's really complicated. I saw an article relatively recently about individuals with sickle cell disease going from different parts of sub-Saharan Africa to India for their bone marrow transplants. And they did well, but they came home and then they didn't hold on to their grafts. They rejected it or had graft versus host because the monitoring was really complicated for that post-therapy. On the giving of the therapy, however, it is easier to do allogeneic transplant than to do the gene therapy. So I think when I think about how we do this on a widespread basis, I think you actually have both options. And I think you're going to have to choose the option that is best for you, but making sure if you do the allogeneic transplant that you have very, very confident follow-up to do that immune suppression monitoring. And if you do the gene therapy, how do we make it so that we get the patient to the therapy in an effective way? So I think we do both to make this as accessible as possible.
Thank you. And Dr. Colombati, you want to add anything on this same question? Great.
No, thank you.
See you. Okay, so we go to the next question. I will ask first to Dr. Colombati, but of course, feel free to jump and add anything you wish. So what could patients do to obtain more access to drug they need?
But first of all, I think be informed. So the first step is really be informed about the drug or the drugs or the procedures, the effects, but also on the process of obtaining the drug in their country. And then lobby with the physicians and all the actors involved in order to have access everywhere. So the lobbying might be continental or national or local, depending on how the process is in each area. So I think the first step would obviously be informed.
Thank you. So now we go with another question for Dr. Cantor. So Do you think there is a possibility of making gene therapy easier to implement as we move forward?
I think some parts of it will be easier as we move forward. The part I think we will see first is the use of a different kind of conditioning. Conditioning is where we give chemotherapy to the body to clean out the bone marrow that's there right now. There are some really exciting potential new therapies that will actually use an antibody mediated therapy, and it will be less toxic. This, of course, will make it more appealing because it may preserve fertility as well, which is obviously very appealing. But it also means that the gene therapy could be done outpatient, because then individuals won't need transfusions on a daily or every other day basis in the hospital. They won't get the terrible mouth sores, and they won't have the severe risk of some of the other side effects of the therapy. So I think that makes it that will be the first increase in accessible way we see doing this. I know there are dreams of in vivo gene therapy. I think we're not quite there yet.
Thank you. I'm addressing one question from the chat. Is there an age limit for accessing gene therapy? Will recipient need to take medications afterwards?
So those are very good questions as well. Currently, the oldest individual, I believe, was around 40 years of age when they did gene therapy. The determining factors in terms of age will be how healthy somebody's stem cells are. All of our stem cells, just like everything else, unfortunately, in our bodies, gets older. And as those stem cells get older, they're not able to necessarily undergo this procedure. I think that that's going to be the biggest limitation. But the second is whether they've had significant amounts of organ damage. We don't know yet how much this gene therapy will improve organ damage. And that is really important, that we don't promise more than we can deliver. Because I don't know that gene therapy will prevent stroke. I don't know that gene therapy will prevent kidney disease. It's why I do not yet call this curative. And I think this is super important. It is a transformative therapy that is unbelievable and amazing. And the patients that I've treated will tell you that. But they do need follow-up afterwards. So the question about taking medicine afterwards is a bit complicated. They won't have to take immune suppression medicine. We know that. It takes a little time if they were on a lot of pain medicine to come off that medicine, but you can come off your pain medicine. What we don't know, though, are will you need to take anticoagulation if you've had a blood clot? Will you need a blood thinner after this therapy? We don't know. Is there a risk of still having blood clots? We don't know. Do people who've had kidney problems and have protein in their urine still need to take their medicines? Maybe. We don't know that yet either. So I think there's so many questions that I would never want to say, no, you would not have to take any medicines, because we just don't know that yet. And it's very important to me that I tell you what we do and don't know, so we don't overpromise and underdeliver.
Thank you. Thank you very much. So I'm seeing one question in the chat, but I would kindly please ask to it's unknown, so I cannot name the person who wrote this question. To please specify, because at least me, I'm not able to understand, because I think the question was done during the speech, so it is missing the subject. But maybe you, speaker, you understand better than me, so I try. Here in Nigeria, which one do you think is to be carried on?
I'm not even 100% sure if that was for me or for Dr. Kalambadi. And so I think Nigeria has a lot of people with sickle cell disease, and we need to bring every available therapy there. I think absolutely we should plan to have a sickle cell transformative therapy center or two in Nigeria, where we can do allogeneic transplants for people who have matched siblings, and where we can do gene therapy. And I think locating a center there is going to be required for these therapies. Dr. Kalambadi?
Yeah, I think it was referring to the transplant and the curative therapies, and probably which transplant or gene therapy would be used. So yeah, I go with your answer.
Thank you. We arrived at the at the meaning of the question. So we read now a comment that I think it's related to the question about what patients could do. So education and acceptance is key to use new drugs. My sepsis use of hydroxyurea is that some parents have refused for their children. Do you experience the same in your consultations, your clinical practice?
Again, the key is education and explain, as Julie said, what we can promise with one drug or we can hope to achieve and what we cannot. But again, being informed on the possible benefits, the possible risks, and reassess frequently. I don't think a decision is made for a lifetime. We can make a decision now and then reassess in a few months. And so it's the use of drugs, old drugs, new therapeutic schemes requires continuous dialogue between parents, patients, and physicians, especially in times of emerging treatments, where it's complicated to choose. We have different options, and we have to choose in dialogue. So I think education and knowing, and then a process of dialogue and discussion. We choose together which risks, which benefits, and probably for gene therapy and transplant, it's even more important to discuss what's best for me. So Julie, I don't know if you want to add.
I think it's so important, that shared decision making. And I've had some people who will come to me and say, I don't want to take hydroxyurea. I'm scared because it's a medicine used in chemotherapy for cancer. But they want to do gene therapy. And I think that we really have to have a deep discussion about understanding that the risks are greater in gene therapy and the risks are greater with that chemotherapy than with hydroxyurea therapy, so that we're really clear what we know and don't know. And I tell a lot of people, but it often takes 10, 12 hours of conversation before we decide to do a gene therapy or a transplant. Sometimes years before someone makes that decision. And that is okay and very acceptable. And this doesn't have to be something we decide quickly. And I think that's important too.
Thank you. So before closing, as we have 5 minutes left, we need to go to the polls we were mentioning at the beginning. And I would please kindly ask the support of the, voila, here goes the poll. And while people are voting, I can remember that now there is another next session in the program. And also I would really thanks a lot, Gansit, for organizing this great conference, and also to our 2K speakers, so Dr. Julie Cantor and Dr. Raffaella Colombati, for having shared their time and expertise with all of us and for sharing those great presentations.
While everybody's voting, there is a question about the cost of undertaking gene therapy. And I think it's important to answer that with the most honest answer of we don't know. And it will be very different in different countries because so much of it depends on what things cost where you are. So here, things are very inflated in the United States. We know that the thalassemia treatment was priced about $2.8 million. And that was only for the cells. It did not include the cost of the transplant. So I think it is clearly going to be very expensive. And we need to make sure that all of the costs the patient need is paid for. So not just the cells, but the transplant, the supportive care, and the housing if they're not going to be able to stay home during that time. So I think we have a lot of things to figure out. However, we're not alone, and that's helpful. Hemophilia has some new actual therapies that have come out that are gene therapies as well, some of which may not even be as durable or long lasting as our therapies. So if those are going to get approved and paid for, we have to fight to get our therapies approved and paid for.
Thank you.